All
Good to
right.
go.
Thanks, Kelly. So my name is Gina Pisano. I'm a Master's of Social Work student and a licensed graduate social work. I currently am working at Chestnut Ridge Healthy Minds, if it wasn't obvious in the title, but figured I'd have to kind of say that. Um, when granted the opportunity to present, there was a couple topics that came to mind, but one kind of near and dear to my heart as somebody who also has OCD kind of sounded like the best option to present as there's a lot of misinformation. So I appreciate everyone in attendance today and happy to pause, answer any questions. A lot of my information is coming from just research, clinical experience of working with people with substance use disorders and obsessive compulsive disorder, and also personal experience as a patient. Um, so happy to answer anything and hope it can be informational as possible and start so kind of just the reason of picking this topic in regards to substance use disorders. There is very little research about the correlation between the two. We know they occur, but there's often, because of a lack of education about OCD, a lack of awareness about the mental compulsions that most patients have. There isn't quite a good capture about how often do they occur together. The two disorders feed off each other. Substance use increases OCD. OCD can increase substance use. Most of the time, when somebody is getting sober, they then have to learn how to cope with the distress of their OCD. Most of the times, that can be like being sober makes my OCD way worse, and so I'm not gonna be sober because that's just too distressful. But really, it's just that removal of that coping mechanism. Um, in long terms, we know that sobriety actually does help, not just with more effective treatment, but also people learn how to tolerate their own distress of their disorder and live a very functional and happy life. So my own kind of comparison, since they didn't do a very good job at researching it and comparing it, they look similar. They have similar qualities. I'm not gonna say they're identical because they're not, but they do have kind of similar motives. The difference with obsessive compulsive disorder is there is the obsessions, the unwanted thoughts, the images. Um, there's more rituals. It's ego dystonic, so it often goes against the values of the patient. Um, and the behaviors are much more distressing. Where, on the other hand, substance use disorders are relative in seeking and obtaining the substance. They gain pleasure from the behaviors. The substance gives pleasure versus in OCD, the behavior gives distress. It's more impulsive. Not to say OCD can't be impulsive. It can, but it's more rare. And there's also a greater awareness of doing the behavior in substance use disorder. They actively know, they are outgoing and needing their substance to obtain their goal. Where they're similar is they have repetitive behaviors. There's that wonderful rinse cycle that both will go through. They're both looking to seek relief from distress. Um, Probably the largest one that I see as in common is it's temporary relief for both of these. Unfortunately, the compulsions don't really provide a long-term solution, and as we know, with substance use, it doesn't really provide a long-term solution. Even though they both look super functional and super helpful at one point in somebody's life, they do end up being super time consuming and causing dysfunction in most of the life. There's also too the idea, it's not on the comparison as I didn't have much room to do so, but is the goal of control. Both disorders seek control in an often a pretty interesting way. Unfortunately, both have to learn that they can't control everything, as that's just you're prisoner to wanting things controlled that aren't your control. Actually, in one of my favorite OCD workbooks, the Serenity Prayer is in there, and they use that comparison. That's often what they have to use in order to have that helpful reminder. So, kind of what is OCD? Kind of tackling that first generalized understanding of like there is a lot of miseducation on OCD. I will be honest, even before I was diagnosed, I had this idea of what it was, not super certain about it. And then once I was diagnosed, I was like, oh my gosh, I was not taught very well about OCD at all. Um, Obviously, the disorder is a mental health disorder, and it's characterized by unwanted thoughts, intrusive images, repetitive behaviors that often help to soothe anxiety caused by these obsessions. It's long lasting. There is no cure for it. You can kind of desensitize yourself and be functional, but it's something that's often most people just learn to live with. And it's very debilitating, kind of as a joke, but I'm really not kidding. So I had to put evidence in there. Um, it's often one of the diagnoses that gets thrown around as maybe not as distressing as most people think it is. There's comparisons of obsessive Christmas disorder, obsessive cat disorder, obsessive corgi disorder. Ironically enough, I own a corgi, but not gonna support that one. But it's not fun. It's not a cute personality trait. It's not a super nice way to be organized. Um, I've also, the obsessive cleaning disorder was another one of those that came up, which actually really disrupts and gives off that wrong perspective of everybody with OCD is super clean, um, which is just not necessarily true, and that everybody with OCD is really enjoying their compulsions. That is not true at all. So really getting the understanding that it was in WHO's, I believe, top 10 most debilitating disorders. Um, and it's a different thing other than a cute way to market clothes. So a quick rundown for those who might not know. The obsessions are often your thoughts. They're ego dystonic, which I mentioned before, which technically means it's something that's against you as a person. It's often against values. It's often your ick thoughts. That's like, whoa, that's not something that I would ever want to think about or I would ever do. They're intrusive, so they pop up whenever, can be no matter what, often when triggers are occurred. They're persistent and they're often fears. So you're constantly with like everyone being in a haunted house 24/7, 7 days a week. Your compulsions are your behaviors. They're repetitive, they're ritualistic. They can be mental, they can be covert or overt. Um, they're driven by the goal to soothe, and respond to these unwanted, intrusive thoughts. And then there's safety behaviors, which I often don't see talked about enough, which are your avoidance, your distraction, your reassurance seeking. Um, Substance use is technically a safety behavior. It's still creating that sense of false security. Most people don't aren't always aware of their safety behaviors because they often have to be pointed out. Um, it's kind of like a protection cocoon, and you're not going to step outside that cocoon. So all kind of play into one another. Ones can look like you could spend hours trying to decipher what's a compulsion, what's an obsession, what's a safety behavior. So just some general stats about OCD in general. Um, Receiving an OCD diagnosis and getting effective treatment can take up to 14 to 17 years on average for adults. It took me 24 years to get an accurate diagnosis. Um, Most of the time, it's from most people can get a diagnosis and then they receive talk therapy, which we know talk therapy is not very useful for people with OCD. OCD is the fourth most common mental health disorder, and 1 in 40 people will develop it throughout their lifespan in kind of the US. Around 3 people of the world's population has OCD. And so, kind of just taking a snip of those stats, I was wondering how many people are we missing in a lot of those, just because we are misinformed and uneducated a little bit about this. Um, and then there were some stats with substance use disorders of patients with OCD. About 13% had a lifetime prevalence of alcohol abuse. Um, of those patients with OCD, 39% were men, 3% were women, and 90% of people with OCD have a co-occurring disorder. Um, but I thought it was interesting. There was not a lot of other substances mentioned besides alcohol in looking for statistics. Um, but alcohol is often used. That's the most common one I hear is for anxiety as like a depressant, a calming, a numbing agent for some people. So I would be interested to see what other substances we can include there. Um, so with OCD, there's themes. Um, the most common ones we hear about and we see in the movies are the contamination OCD, which is, somebody having obsessive thoughts about germs or any type of illness. And we always see it in the movies, they're cleaning. That's not really what it is. A lot of the times it's, obsessive hand washing. There are cases of people eating soap, um, you know, taking it to extreme avoidance, things like that. But there are more themes than just that. So harm OCD is typically um, where people often have a very difficult time being around objects that could possibly cause physical or mental harm to somebody. That's including knives, guns. Some people won't drive a car. Um, it's just kind of I don't want to cause harm to somebody. Moral scrupulosity is often fear of being immoral. This can also go with religion. Um, we often see like obsessive praying, horrible boundaries because they don't want to hurt anyone, um, telling on themselves, reassurance seeking, not wanting to make mistakes. This can look like perfectionism, um, and it often does have a decent amount of mental compulsions. Ironically enough, this is my theme. So there is a lot of concern with being, correct on these things and being right and having things 100% of the time on it because fearing of being looked at as a bad person or an immoral person. There's sexuality OCD, which is often questioning one's own sexuality. That can be really difficult and actually play into the next theme, which is relationship OCD. Can be like thoughts of what if I cheat on my partner and I don't remember? What if I really don't love them? What if I'm looking for just the right one? I don't have that feeling in my stomach. It must not be right. It can be quite distressing and impact a lot of people's relationships in very difficult. Then there's Puro, which is becoming more known. It is void of any external compulsions. It is just pure obsessive thoughts, intrusive thoughts. Most people don't realize that they have Puro because there is no external compulsion. It is just continuous, no relief. Um, Most of the time it's just mental compulsions of just the back and forth in your head of like, no, don't think that, yes, think that, but what ifs, quite distressing for a lot of people who do have Puro. The just right OCD is often where you will see people wanting things this is where that like idea of particular, oh, I'm just particular or I'm just organized comes from. It's really not. There's often an obsessive thought behind it of like, if I don't have it just right, something catastrophizing will happen. Um, And there's several different types of how this can look like, and can flood into all areas. Pedophilia OCD, which is, I would argue, one of the more distressing ones, is there's cases of people who are teachers and have this and quit their jobs because they're too terrified of their thoughts. This is very much not to distinguish of like there's a sexual motive, but it's more like, oh, a child looks cute in that picture. And then the intrusive thought is often you're attracted to children. And it's just going back and forth, back and forth. And I think a lot of people are very quiet about this theme, as there's a lot of stigma and shame with the possibility of, oh my goodness, what's somebody going to think? Somebody's going to report me. I'm going to go to jail. Um, Very, very much empathy to those who struggle with it, as it's sometimes a quiet fight with themselves. Um, Real event OC is, this one's haunting. It's because it's real times where you reflect and you go back on things and you're almost reanalyzing if those things actually happened. And there's cases of people having extreme trauma and still struggling to know if what was happening was real and if that was actually what was going on, if their opinion of it was it actually as bad as they made it out to be. It's often just really questioning your own experience. The themes are important to know, but no matter the theme, you're going to treat it all the same. Again, I have several different types of little blips in here, but my main core is scrupulosity. No matter what, OCD latches onto anything we care about nor we love. It switches themes whenever we desensitize ourselves to one and it chooses a different one. So you will go all day trying to treat the theme. There's no point really, because you're just going to have to do it all again with another one. And the other point of mentioning the themes is there's a lot of them that carry a decent amount of stigma. And when I think of the world of substance use and somebody, you have that patient that comes in and doesn't want to share the real reason behind what they're trying to cover up or do, or what the alcohol helps them with or the substance helps them with. I always think of what do they not feel comfortable sharing or feel ashamed of sharing or scared of sharing? And I think a lot of these themes do a really good job in scaring you into not telling anybody what you're going through. So it's also makes me kind of empathize of how many people with OCD truly rely on their substance to not feel the shame of having some of these thoughts. So kind of just the basic OCD cycle. You have your obsession, your unwanted thought or image. You have that distressing ick feeling. Then you have your compulsion of I got to get rid of this. I often phrase it as, think of it like hot potato. If I throw a potato, I know Sarah's here watching this, in Sarah's hand, she's going to get rid of it because it's too hot. It's the same thing with, I have an obsession, I feel the distress, my compulsion is I got to get rid of it. And there's temporary relief, and then the obsession comes back. So it's just that same rinse cycle of doing the same thing over and over again and thinking it's working. Again, another saying we often say in recovery. So there's two case examples that I have. Both demonstrate two different types of ways I've seen OCD show up in my personal practice, and also what research says kind of the two different lines are. In the world of OCD, treating it is a safety behavior, substance use is. It provides temporary relief, it quiets the intrusive thoughts or images, and it eases the physical anxiety symptoms. I currently work with several different people who do have that self-medicating route, especially with anxiety. And actually, my case example came from this. This is somebody who I saw Um, Male, 43 years old, alcohol use disorder. I diagnosed them after assessing and noticing a history of obsessive thoughts and compulsive behavior. Um, OCD features and traits presented all throughout childhood. The patient themselves knew, just never thought to bring it up to anybody. The substance in this patient's goal was used to assist in soothing the anxiety felt. It was a lot of pressure. It created a lot of rigidity and a lot of resentments for this patient, which would then cause them to, you know, just kind of give up along their way, dismiss people. There was a fear of failing. Um, and also, this is the case of the cases of lack of boundaries, which then cause resentments not only in recovery communities but interpersonal lives, creating that sense of isolation, which only more contributed to the use of alcohol. Um, this was a good example as well of moral and just right themes, but both are at play at the end of the day. It can switch no matter what. Um, but kind of a good example, and this person was 43 and had never had a diagnosis on them. They knew themselves they had something that resembled OCD, but just never thought to bring it up because they didn't think it mattered that much. Um, and they're doing well, and we're actually, into the place of sobriety to where we can work on exposures and work on addressing some of those symptoms that for so long they just dealt with themselves. The second kind of idea is when it becomes part of a ritual. Um, a substance can easily become part of somebody's obsession, can be attached to one of those thoughts, um, can get swept up in the cycle and just become compulsive and ritualistic. I have a 28-year-old female with OCD of themes of just right, and they use Delta 8 and marijuana. And the Delta 8 pen was part of their nighttime routine. For a while, we would try to discontinue that, but it was just too much distress to pull that out of that routine, or else it wouldn't be okay, or something bad was really going to happen to this patient's family. And so the fear of just stopping the substance outweighed anything we could pose. Ironically enough, it stopped once the pen just was lost. And it was already out of routine, and we weren't going to touch the routine again. But the patient noticed that, like, I'm actually sleeping better without the Delta 8 and the marijuana. I'm less paranoid. I'm not as anxious towards nighttime. The intrusive thoughts actually decreased at nighttime, which made going to sleep much easier. Unfortunately, we know marijuana and Delta 8 can cause some paranoia. I would not pair that with people who have intrusive thoughts, or anxiety disorders. Doesn't work very well. But yeah, once the cycle was broken, that they no longer use marijuana, and they're like, yeah, I have no interest at all of obtaining that again. And when we think of it being this compulsive behavior versus this addictive behavior, the compulsive behavior outweighed it way faster than, oh, I'm using this substance because this, and that. It was just too distressing to let that disruption occur. And it was an unintentional exposure, but it worked. So, and now we're like, I don't care. So, super interesting to see how there's two different routes, in which both are kind of playing out. Um, and as you're being a practicing person in the recovery world, in the world, if you come up with OCD, there's just a couple things I would love to address of, like, saying just don't think about it isn't going to help. I've already thought about it 800 times. Our patients already thought about it 800 times. If they could just stop, they would. Same as the same thing we do with our patients with addiction of like, if they could all just stop, they 100% would. Saying I'm so OCD, now if you are, that's fine, go for it. But if you're saying it in in the quirk of, being particular about pens or things like that, um, probably not the best idea. It's just perpetuating to this more of the misinformation surrounding OCD. Kind of the same, just stop worrying about it. Would have done that, tried that 18 thoughts ago. Um, OCD must mean you really have a really clean house. This is one I've heard personally. I don't. I'll just be honest. And most of our patients don't even have the energy to clean their house when they have OCD or they are struggling in active addiction. That is not their concern. They're coming to you for help, not for you to compliment them on how clean their house must be. Um, and super organized person is another one, and often, maybe they are, who knows, but that has nothing to do with the disorder. It's often when people bring up they have OCD or anything or are seeking help, it's nice to just, same as you would if you yourself are not somebody in recovery, just listen and try to understand the best you can. Um, don't try to disprove the intrusive thought. I know it's the common classic of like, well, tell me why that's not going to happen. I already know it's for most people, and there's a really good book that I can provide to everyone here of this back and forth, that disproving is just giving that false comfort. It's feeding it. And I'm going to come back with a, but what if? And what about that? It unfortunately, if all the evidence in the world, I still am going to have that. I want to know 110%, not even 100%. And I actually see this one a lot with patients getting wrapped up in the thought, and I often hear thought spirals and things, and that's kind of like I can't deal with my thought fibers, so I need to use something. I see it very often, how invalidating that and scary sometimes that also is to have. Don't participate in the rituals. Um, it's definitely, working on that same line of not enabling. So when it kind of comes to the sense of, well, I'm just going to let them do it a couple times. It's like that's not helping anybody. We same with substance use. It wouldn't help anyone. And not giving the constant reassurance. Um, there's a difference between information seeking and reassurance seeking. Absolutely give the information that is needed, but giving them constant reassurance that everything's fine, nothing's going to happen, you won't do that, is another way of just feeding it, and continuing that cycle. It's just false comfort. There's different treatment options. The number one recommended way is cognitive behavioral aspect, or cognitive behavioral therapy. Some aspects of it are helpful. And then, like I said, there's others that can actually make it worse. So I would say a blend of all three of these is wonderful. ACT is often a great way of helping a patient just learn to sit with discomfort. I also use it a lot too for my substance use. You have to deal with your cravings and sit with your cravings and sit with these thoughts of use. And, the more you think about it, and the more you don't want to think about it, the more you're going to think about it. ACT, I'm also a patient of ACT. This was what I was treated with along with ERP in my own personal life. It created a lot of self-compassion. I use it a lot with a lot of my patients that do have OCD, also who have substance use disorder. And instead of fighting it with shame and anger and disappointment in yourself, there's a different line. They beat themselves up enough. Let's change it because that's not working. And just dealing with the uncertainty. We know recovery and sobriety brings a lot of uncertainty, and so does OCD. And both are paired very wonderfully. especially if you're treating both. So exposure and response therapy, it desensitizes those to their obsessions, and often it's by taking away the compulsion, sitting with it over and over and over and over again. Exposures can look like anything. There can be scripts, there can be reading material of doing it. You can actively go and, there are cases of people like actively going out and doing them. I think there was one that was, oh, it was this show I was watching, and it was a case, but um, it's not uncommon that most exposure therapies will have knives for people with harm OCD, and you will hold the knife up pointing at the therapist, or they can look extreme, but the one thing is the if that's somebody's intrusive thought or their obsession, they're not going to do it. The reason they're avoiding everything is because they don't want to do it. They are more likely than not going to act on that. And it can be really difficult for patients. As somebody who did it, it sucked, but it was so helpful and it changed the game. Most of my patients didn't like it at first, and now they, on their own, are finding their own exposures in different ways to do it, um, and learning how to kind of sit with this. And knowing that, there are other options other than your substance use that can provide you relief is, I think, the biggest hope for a lot of them. And that's kind of just my takeaway. If there's any questions, comments, concerns, um, please feel free to let me know.
Gina, that was such a great presentation and a really good reminder for me to not accidentally reinforce certain, behaviors or compulsions if I'm not careful. So that was a really good reminder. Thank you.
So hard because it goes against everything you are told to do as a therapist,
Yeah, yeah,
which is
yeah,
provide comfort and help. And
yeah,
but yeah,
yeah,
sometimes you have to pose the opposite.
yeah. Yeah, that was really, yeah. As a therapist and codependent, I needed that reminder. So thank you.